without further delay, if we can invite Dr. Adams. Dr. Adams, Roisin Adams, is pharmacist. He's a pharmacist, a trained pharmacist from Ireland, the University of Belfast. She was also trained in the Center of National Healthcare Center of Pharmacoeconomics, and maybe most relevant to today, she heads the coordination group. So thank you very much for being here and for making it. The floor is yours.
Thank you very much, and thanks very much for the invitation. Caroline has really put it up to us, what we have ahead of us in 2025. So I'm going to take you through a little bit. I'm conscious people have maybe mixed knowledge of what's ahead of us. Can you?
Sure. Is that better? Yeah? Okay. I'll try and hug the microphone. So we're working very fervently towards the 12th of January 2025, when this is fully implemented. Just don't know if this is my first slide, but okay. Anyway, I'll work forward. So I am chair of the coordination group, which is the overall governance structure for the HTA regulation, and under which all the work will be overseen, I guess. The structures that are in place at the moment is the coordination group, which has each of the member states represented on it. There are a number of different representatives from different member states. We've taken the decision to meet in both configurations of medical devices and medicines together, so everybody is there in one room. We have now established 4 different subgroups, and you've already heard the terminology, but I will try and use the full words. Joint clinical assessments, which is one of the subgroups. Joint scientific consultations is another. Then we have a methodology and procedures subgroup, which will oversee both scientific methodologies, but also the procedures, or how we work and how we will actually undertake a lot of this work. And then finally, we have an emerging health technology subgroup, which very much links to what Caroline was just talking about, trying to plan what's coming our way, and how we can build in some of the criteria that are described under the HTA regulation into that planning. The group are required to publish a work plan from 2025 onwards, and the work of this subgroup will very much feed into that. We're supported by a secretariat provided by the European Commission, and that secretariat is required to provide administrative support, IT support, and I guess technical support in terms of procedures and compliance with regulation, etc. There's a very important aspect within this, which is the IT platform, which really is our virtual space for how everybody can interact with the system. And it goes from submitting your dossier of evidence to assessors being able to work together in their respective countries, as well as this stakeholder network, which is many of you are probably part of. And there's also a mechanism to share information with the stakeholder network and take information from the stakeholder network. I think that's most of what's on that. We have the chairing, who actually chairs each of those groups. So obviously I chair the coordination group, but I'm in good company with Marco Marchetti from Agenas in Italy. He represents the medical device side of things, but also Nicholas Hedberg, who comes from TLV and would have the specialty in pharmaceuticals. Then, within the subgroups, we have France, our Haas, chairing the Joint Clinical Assessment subgroup, and we have in the Joint Scientific GBA in Germany. And also for the methodology, we have ICWIC, so Beata Wiesler is chairing the methodology, and then we have Denmark are chairing the emerging health technologies. Each of them have a co-chair as well, so I won't go into all of them, but we have Anne here who is co-chairing the joint clinical assessment at the back. Yes, Anne Williamson from Zinn, who's co-chairing and doing stellar work there. Okay, so that gives you a little idea of the setup of how it's all going to, and that's the architecture really of the governance. Let's focus a little bit on the joint clinical assessment, because this is the main mandated report that will be conducted. And what we're talking about here, as many of you know, is comparative effectiveness. So while we have, of course, the risk-benefit that comes from the regulatory process, we have this, how does this perform, if you like, when you put this into clinical practice in the respective member states? So what is the added benefit that this would provide? And I'll talk a little bit about what the actual report will say and what it won't say, more importantly. So it is required for all newly authorised medicines. I think Caroline referred to the phased process of how it will be introduced, but ultimately when we come to 2030, it will be for all authorised medicines. So 2025, as is said, oncology and ATMPs will be introduced. From 2028 onwards, we will add in all orphan medicines, and then from 2030, all medicinal products, including vaccines, which is in the regulation as well. In terms of medical devices, the timelines are slightly less clear, I would say, in that the mandated dates are not specified in the regulation. But we're trying to work towards that and try and set the group up and do the preparatory work in relation to medical devices. The scope, as I mentioned, is comparative clinical effectiveness and safety of the product being assessed. I thought it was my eyes a minute ago. I thought I have to get new glasses. It's very much a clinical assessment. It doesn't include cost effectiveness, although you would argue that the voluntary article may allow some joint working between different countries for the health economic, if you like, or the non-clinical domains as it's known. It is a scientific analysis of the relative effects. And this is important, including the degree of uncertainty and degree of certainty, or indeed uncertainty, and strengths and limitations of the evidence. So that is what the regulation requires us to describe in the report. What it can't do, and this is also very important, is it can't make value judgments. So it can't say that this product has an added benefit. It just has to describe the metrics around it. And then when it goes back to the member state, they determine their acceptability, if you like, around the uncertainty by determining whether it does have an added benefit or insufficient added benefit within their national system. And that's a really important factor, and it was key to the whole regulation that this does stay at the member state level, because I suppose this is very much related to the decision making at the member state level, and in turn cost and price and all those negotiations that follow. The JCA report, a Joint Clinical Assessment report, is mandated at the national level. So, and this is where the devil is in the detail, I guess. It's not explicit on how that should be done. So whether it is as simple as appending the Joint Clinical Assessment report onto the national report, which we hope it goes beyond that and actually forms a really key component of the work that's done at the national level, because that's where the value is leveraged, that we save a lot of work, both for assessors, but also for health technology developers who are submitting this information. Okay, the other key output that we have is joint scientific consultations, and these are early advice. And this is really seen as a really valuable part of the picture, because it is, it's no secret that we have a major challenge with our evidence dossiers, if you like, for HTA. And there is often quite a bit of uncertainty by the time it reaches HTA in terms of comparative effectiveness. So the obvious place to start is at the beginning, when we're doing the clinical trial designs, and what we're hoping to do is produce the questions that we will ask at the HTA level early, so that the preparation can be done in terms of clinical trial design to address those questions. Because all too often, we're asking those questions at the end of the process, and there is no time to collect the data, and it becomes a very difficult scenario. So we're very much hopeful that the joint scientific consultation process will deliver in terms of producing a better evidence package by the time it gets to the JCA. Okay, so in terms of, there is no phased introduction for joint scientific consultations. So in theory, health technology developers can come and ask for a joint scientific consultation from 2025 onwards, and it doesn't matter what product it is. There is some room there, of course, for the HTA coordination group to introduce some prioritization criteria. It makes sense that you might want to look at oncology ATMPs first, because they are the first JCs we will do. So it's possible to do that. And of course, orphans will come very quickly after that. So that may be the scope. But it's quite important that there is no limit, actually, on what we need to do. So that's the resource question that we'll have to, I may end on. The other important point to mention here is that we have recognized that joint scientific consultations are incredibly valuable, and in 2024, would it be possible to continue to do the work that we have been doing with the EMA during UNITA 21, which of course was a service contract where we were doing quite a few joint scientific consultations. And there was agreement reached that we could try and continue this in the interim period. And the EMA have agreed to continue that, along with GBA are going to coordinate it, but there will be many other member states also involved in that work. We may not do that many, but I think it's important that it's continued so that we do maintain those learnings. Okay, there is a rolling plan on the European Commission website, so I didn't put it up here. What we have now is we have the architecture in place. We've had quite a number of HTA coordination group meetings at this point. We are starting to move towards a consolidated work plan. At the last meeting, some of the key aspects that we were looking at, and there's a flash report, these are all published on the website. We were looking at aspects such as medical devices. Can we start with joint scientific consultations in the coming years? A challenging area, because of course medical devices is a little bit less clear, I guess, how it all fits together. And obviously the EMA are just starting to work on this as well through the expert panels. So it is in its infancy, shall we say. The other points that we had discussed was around the implementing acts, of course, which are to the fore of many HTA bodies, health technology developers, patients' minds at the moment, because this really describes how we will do this work. And it's legislation, so we have to be mindful that we get this right, and because they won't be easily changed. So there were some of the key aspects that we were discussing. We also, of course, had the finishing of UNITA, which was, I think there was a lot of sadness in the room and nostalgia, because it was a wonderful, the work that was done under UNITA was wonderful and has really brought us to where we are. So they were some of the key points that we were discussing. In terms of the implementing acts, it is incredibly challenging. We are trying to set up the procedures of the coordination group, but also have this legislative plan running alongside. And it is, we're very conscious that we didn't get to do pilot joint clinical assessments during the service contract, which means we haven't tested a lot of the procedures. And that is challenging when we're now talking about putting those directly into legislation. So, and the key areas I think that are most challenging are timelines, of course. We have a very defined, we have to publish this report 30 days after the marketing authorization. The health technology developers have to submit 45 days before, well, at least 45 days before CHMP. And obviously, you only have the certainty of knowing the indication at CHMP level. So we have all of these factors playing in, and it's a balance between reducing the uncertainty of the preparatory work. So if we start too early, We don't know so much about the indication, and if we start too late, we have less assessment time. So it really is a careful balancing act. And this has to be built into the implementing act. So the scoping is a key area for certainly for health technology developers, but every member state around Europe as well is grappling with how do we actually frame our question or questions, as it will be, and also the dossier. What do we submit? What do we put in the implementing act? We haven't tested it, so ideally we put less detail, but then by all accounts, we need to have some detail in there. So there's a lot of really significant choices that will affect our process in the future, having to be made within a very short period of time, with, I would say, not enough experience of the current guidelines that we have developed. So, that being said, these are the complexities. This is just one aspect, okay? So there's a lot of questions about the scoping, and I put it up here because we hear the questions, we understand them. Can the health technology developers come to the table? Can they submit their own question, if you like? How do we take input from experts? How do we separate the idea of the patient or clinical expert from a stakeholder? I think of these terms now as distinct, where we're really asking a patient or clinical expert to come to the table to bring a non-advocacy role, if that makes sense, really to talk about the specifics of the disease. And then there is this idea, and I know, Jörg, you were talking about a lead PICO or an EU PICO. I would caution going down that road just yet. We haven't brought everybody with us. So it's not, we're not going to get to a point of one European PICO. So sorry, now, to burst that bubble for now. But we are going to move closer. We're going to move a lot more closer and to become, I'm not sure I would say aligned, but certainly we do have we have different health systems around Europe, and we have to acknowledge that. Ideally, we start to gravitate towards the center, if you like. We will have multiple PICOs. Because we have multiple questions, and we do have different systems, but we'll get there. The bigger issues. So we have these very difficult technical questions, lots on scientific guidelines as well. But we also have almost no resourcing for the system, I would say. We have to think about a future governance structure. Where will this be? What system will it be within? National implementation. This has to work at the national level in order for it to really reap the rewards. And it's almost impossible now, finding the space and really the time to build something that works for all of us. And that is one of the most challenging aspects at the moment, for the reasons that I describe: setting up the coordination group, implementing acts, lots of aspects going on. I think really what we need to be clear on, I suppose, is the distinct functioning of what HTA will offer. And I know we've had lots of conversations, Michael, and it is important to really be clear about how this is distinct from regulatory and what questions it answers that are not answered at regulatory because it's not required. The solidarity, of course, bringing us together, always focusing on the center and what we're trying to do, which is bring more effective medicines to patients. Scientific excellence, this is important. We have a lot of discussions on the methodological underpinnings of what we're doing. And sometimes we agree, sometimes we don't. I also see that starting to, all of us do things slightly differently. Some of us have cost effectiveness frameworks. Some of us have added benefit frameworks. And it's just understanding the perspectives that people are coming from. It needs to be responsive. The timelines are, yes, as I mentioned, but also responsive to other questions that health systems may require. And it might be something about, what we've just gone through. It's a bit like, don't mention he who should not be named, the pandemic. But being responsive to those kind of questions as well. And then the enablers, of course, resource, but cooperation and intelligence, which a little bit like what Caroline was describing, but we need intelligence within the HTA sphere as well, which gives us insight. And because of the sensitivities around some of the information, we need to have something that will and it may not always come from the EMA. We may need to have our own intelligence system, but looking to, I suppose, complement it with other pieces of data. So that's, I think, all I have. Hope I haven't depressed everybody too much.
Thank you, Roisin, very much for this presentation. And also thanks, honestly, for taking on this job. This will keep you busy 700 days per year, I'm sure, you and your team.